Hello, 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 and good evening. And thank you for joining us here on blackdoctor.org. And this is that show you know you missed. You didn't know you missed it, but you missed it. This is House Calls with Dr. Gigi back on blackdoctor.org. Of course, I am Ellis Dean, the Director of Digital Programming on Black Doctor. And tonight's show is really, really unique. And we have a wonderful guest that you can see there, Miss Tracie Bass. But tonight's guest, because we're going to ask the question, and we're going to try to get some of the answers of what do you do if your doctor doesn't listen to you? And we're going to go beyond that surface of advocate for yourself, right? Because that's such a big thing. Like there's so many different ways to advocate for yourself. That what does that mean? We're going to peel back some of those layers tonight and get our hands dirty and talk about. We're going to share some stories that are really tragic. And Tracie's going to talk about her experience, and she's been in healthcare since she was a teenager, so she can tell you a whole lot of stories. But we're also going to kind of talk and peel back those layers and say, look, okay, really, what is people of color or people that are undesirable? I use those air quotes that just don't get the best treatment. What do they do, and how do they really advocate for themselves? And so I'm really happy for this program. I'm excited to have it because this is what really the work that Black Doctor is doing. When we post those articles, when we do this programming, we're really getting down to, hey, this is all about advocacy work. And now we're getting to the crux of the matter. So I know you didn't sound on to hear me talk. So I'm going to say good evening, Dr. G.
Good evening. Good evening to you, Mr. Ellis, and good evening to our special guest, Miss Tracie, who I'm going to introduce in just a second. I was on a little hiatus, but you know what? We're back. We're going to be every other week, Wednesday at 8 o'clock. And really, I would like to hear from the audience about what particular topics you might be interested in hearing about, because really, this is your show. I mean, I have an idea of what I see as a physician and see out there when I do work with the Rodham Institute and our over 160 community partners, but, it's helpful to know what people are interested in. So I want to talk a little bit about why I had this idea for this show tonight, and then we'll introduce Miss Bass and hear her story. I am dismayed, disturbed, troubled about what's been happening in our country. For many of us, COVID was just another example of what I like to call medical apartheid. Let's just be real. We've been seeing over and over and over again the worst outcomes among Black people. We'll talk about people of color overall, but I want to really focus on members of the African diaspora because other than Indigenous people, Native Americans, African Americans have the worst outcomes. And of course, we know the history of our Indigenous brothers and sisters. Numbers wise, unfortunately, they've been wiped out. So the numbers are not that many. So, for all intents and purposes, I'm speaking about African American, of people of color, but I want to focus on African Americans. COVID showed us how much the disparities, what that costs in human beings' lives. We saw people dying, and it wasn't just a theoretical thing. We knew people that died. We knew parents, grandparents, uncles, aunties, cousins, friends. And here in Washington, D.C., we were the seventh per capita in the country in terms of African American deaths. And at one point, something like 1 in 3 Black people knew somebody that had died of COVID. And at that time, there was some interest, and Dr. Fauci, of course, spoke about the disparities, and I give him a lot of props. He said, "This is just the latest example. What are we going to do?" And then, of course, just like everything, there's a fad, and it kind of runs out, and DEI and implicit bias. Oh, we got to get more diversity and so forth. But then we heard about the devastating news of all the rollbacks of the Supreme Court. But before that, I was just getting a sense, because of the stories that I was hearing from my patients, that there is a shift. and it started with the previous administration. But what does that mean in terms of individual lives and individual stories? So, with that, I'd like to introduce my little sister, Ms. Tracie Bass. I've known her for a long while. And I asked her to join the show because she has a unique perspective because she works in healthcare, but also is going to be talking to us about her story as a patient. So, welcome to the show, Ms. Tracie Bass. Nice to see you.
Thank you.
Can you tell us where you're from and how did you get up to Washington, D.C., what
I
your
was,
journey was?
of course, I was born and raised in rural North Carolina, a little town called Ahoskie. After graduating high school, I went to Morgan State. I had a child, stopped school, and started working. Landed in Manassas, Virginia, actually, with a urology group that all graduated from GW. They liked me so much, they cared about my commute, that they helped me get a job at GW. So I started working at GW, checking in patients at the front desk. That was the first job that I had there. And then I moved along and I became a medical secretary. I left there, went to the ER, and I was working the ER part-time, GW's ER part-time for many years. And then I became the residency coordinator for medicine at GW. And then after about 12, 13 years of that, Rodham Institute was created. And so Dr. Gigi and I moved along to the Rodham Institute. But in November of 2021, after getting my third injection of COVID vaccine.
And this is no cut against the COVID vaccine, right?
No, absolutely not. It's not. It was a Friday afternoon, and usually when Dr. Gigi had clinic, I would come to clinic with her to make sure we get things done for our patients very quickly. So I was sitting in clinic, and then I was having this tingling pins and needles in my fingers and in my toes. And it was so bad that I was in tears. But because of some medical history, we thought maybe my magnesium was low. Let's go check your labs. I'm going to order your labs. Go get your labs done and then go home. Of course, me being me, I didn't get the labs done. I just went home. So Saturday came. The pain was moving. It was like literally moving from my fingertips up to my first knuckle to my second knuckle, and the same thing on my toes. By Sunday morning, it was so bad. I was like, I've got to go to the hospital. I have no choice at this point because nothing that I was taking over the counter for the pain was helping me. And at this point, I knew that it was neurological pain. Like, this is neuropathic pain, and nothing I'm going to take is going to help me. So I drove myself to a hospital that's here in Prince George's County. It's like a mile from my home. Parked my car, went in, checked in. And like I said before, I've been an admissions person in the ER. So I want to say that I think that patient care begins at the desk when you check in, not when you see the first clinical person, because the person who was registering me was so offsetting and made me feel like she thought that I was a drug seeker because my complaint was pain. So I checked in, I'm like in horrible pain. And I was like crying nonstop for like an hour. I sat there and I still hadn't called Dr. Gigi yet because I was like, let me just wait. I might not need to bother her with it. So time went on. After about an hour and a half, hour and 45 minutes, I called her and said, hey, I'm here at the ER. We know somebody who's connected to this place. Could you please call them? Because I'm just sitting here, but my pain is so bad that I had a child without any medication, and this was worse than that.
Okay.
And so she said, sure. So immediately once she made the phone call, the game changed. Oh, come on, we're going to take you back now. Let us. So they took me back. But the nurse would not listen to me. I'm telling her, I'm like, I have a history of migraines. I take Botox for my headaches. I don't have diabetes. I don't have I don't have high cholesterol. I take rosuvastatin as a prophylactic because of my family history. So she says, "Are you a nurse?" I'm like, "No, but what does it matter?" So she's like, "Well, I can give you some Dilaudid. We can get you some Dilaudid." I said, "Dilaudid is not going to help me. Like, this is nerve pain. I know it's nerve pain." And she's like, "Well, you'll just have to wait." So they put me in a room on the cardiac unit. And I'm being basically ignored for about 3 or 4 hours. A physician came in, a resident, and probably, I think, maybe a medical student. And so when they came in, he was like, the physician was very nice. He was like, "How are you?" I'm like, "Not at my best, And then he's like, "Okay." He was like telling me what's going on. And then it was so interesting that once I told him that I was the residency coordinator for 15 years, it's like everything switched immediately. Oh, okay. Well, we're going to do this. We're going to order this. We're going to do that. We're going to do this. But prior to that, from the beginning, everything that I was offered was pain medicine, as though because I'm a 40-something-year-old Black woman coming in the ER and saying that I'm hurting, that I'm automatically a drug seeker. So I said, none of that stuff is going to help me. So by now, Dr. Gigi is in the background working to get me transferred first thing in the morning to get out of there so I could go to GW and get and get what I needed. So it was just horrible. And then they would not let me finish speaking. As I was speaking to the nurse, as I was speaking to the doctor, they would just cut me off like mid-sentence. Like I would say, "Well, I have a family history of this, but I just got the COVID vaccine 10 days ago." And I said, "I'm thinking back to my second dose. I had some of these same. Oh no! It can't. That's so rare. Guillain-Barré is so rare. It can't be that, because if it was the second time, the symptoms would have developed and you would have gotten it fully." I'm like, okay. So I'm just praying, let me make it through the night until this ambulance service can get here and take me where I can be treated. They came the next morning. I went to GW. After about 6 or 7 hours, Dr. Gigi was in clinic. The pain was so bad, I literally called her from my cell phone to hers, and I was screaming and crying. I'm like, I can't even explain this pain to you. It's so bad, and nothing that they're giving me is helping me. Nothing and full disclosure, at GW, the treatment that I received was very different, because half of them used to be my residents, half of them are my patients. So, it was a very different experience at GW. So my neurologist, she was doing her best to treat me, and the pain was just so bad that you just like, no, we have to call pain management, because I've known her for so many years and I've taken care of her, and that I can tell from just talking to her on the phone that her pain is like, it's really bad. So I ended up on lidocaine and lithium.
Ketamine.
Ketamine. I'm sorry. Ketamine. Ketamine. I'm sorry. Please excuse me. Ketamine and lidocaine for 3 hours a day for maybe 3 days. And I mean, I lost days along the way because I was sleeping the entire time. And that was the only thing that would help control the pain. And if I would have stayed at the other place, I'm almost certain that if the pain would not have killed me, that it would have affected me in a way that was so bad that I probably would have wished I was dead. It was horrible. And afterwards, it's such a Guillain-Barré is so rare that it's so far from what people even think about. When you're saying you're in pain, they think of everything else. And then here you are, that 1% of people who get it, and to be somewhere where they're not even considering that or even thinking about that being an option. It was very difficult for me. I was in the hospital for about 10 days. I had to take occupational and physical therapy to get my walking back together and everything. And it was a very, very tough time. And it made me actually reflect on myself from when I worked in the ER. And when I met patients who came in who were frequent flyers, who, the folks who had sickle cell, and it took me to a place that I had to do a self-evaluation, because working in these settings for such long periods of time, you become jaded. Most people do in some way or another. And I had become jaded, but I didn't realize it until that point, that I was the patient and everybody thought I was there just to seek drugs. And so it was a very, very difficult time for me. Recovery was long and hard, but I made it through. And it's amazing. It has changed my outlook and made me think twice personally about things that I may have done and said when it came to patients. Because frequent flyer, drug seekers, all of these were terms that as staff we used to describe people. Like, people will walk in the front door, and by the time they sat in my chair, I would already have them registered because I already knew their name, date of birth, everything, because I had seen them so much. So
I'm guilty. I'm guilty of that. I worked in a psychiatric emergency service, and late at night when it got to be, we knew if it was cold, if it was raining, we was gonna have a flood of people claiming to be suicidal, and we knew we would just let them sleep in the front and send them on, because we knew that they weren't really suicidal, and we just kind of really didn't even, And I'm saying this matter of factly, but I'm really kind of lamenting some of the behaviors that but you get caught into that with the residents, with everybody, the staff, everybody. Oh, that's so and so. He's always up here on Friday night, blah blah blah, and
it trickles down. It actually trickles down. And as a residency coordinator, I always try to tell my residents to not become a part of this, because it will actually affect patient care. And I've done it. You'll do it. I can't imagine. I can't think of one person that I know that I work with in the ER over 25 years at North Carolina and DC who I didn't see at least one time do or say some of these things, because you get to a place where you just look at a person and assume that they are there for exactly what they've been there before every other time, which is not good.
So Tracie, thank you for sharing that, because that kind of gives a real life example of what we want to discuss some more. So I just want to kind of explain medically what you had for the audience. So you had a type of Guillain-Barré which only manifested in a sensory way. when we think of Guillain-Barré, which is a really, really rare side effect, it's not 1%. I think there are a couple of zeros in before that point something 00%. Usually it's weakness. And so it's easier to recognize from the standpoint of the physician or the clinician, because what people will describe is it's called ascending paralysis. But yours was ascending pain, ascending sensory neuropathy. And you were using that language and you were not listened to. Now, you know, as you said, there are lots of reasons why people are not listened to, right? Because we're human beings, right? I mean, we have to separate out the individual behaviors versus the system behaviors, because, and it's important to separate those out and then put them back together, because the reality is, and I'm just going to speak about medical students for a second. Medical students usually go into the profession for all the right reasons. Nowadays, you have to do all this community work. And, you know, when I was in medical school, basically you didn't need to do all that. And so they're in the main good people. But what happens during the course of their training that makes them that person that at the end of their training, they start referring to people as, you know, frequent flyers and not really listening to you, oh, just do this and that. So I want to give you an example. If there are two women, both with pneumonia, one is a college professor, the other one is a homeless, HIV positive woman with schizophrenia in the middle of a psychotic break, who is easier to take care of? Well, it's a no-brainer. The college professor is, because we can understand her. We tell her, take your medication with food or refrigerate the medication, or if there's a problem, call us back. And if she can't get through because the phone system is dysfunctional, she can call her friend who works in the medical school and get through. There's ways to navigate these back channel ways because she's familiar with the system she can navigate. But what happens to that other lady? Well, it's hard to take care of somebody who's in the middle of a psychotic break.
Yep.
Right? They may be yelling. I mean, Mr. Ellis, you're a psychologist, so you know this better than anybody. She might be yelling. She might be even kicking, biting, spitting because she's not in her right mind, right? And so what happens is that in a system which does not have adequate resources to say, okay, we need to get you just a psych liaison to be able to see you, or we need to give you one-on-one, it's not only nursing, but the appropriate people that can help to calm her down and just reorient her, because she'll have a familiar face instead of her just yelling and not being listened to. So then what happens? Okay, you know, in teaching hospitals, you have a whole team that rounds, right? Well, after a while, the team doesn't want to be with that, you know, person or to round on her. So it may be the medical student or the intern that will round by themselves. So with time, what happens is that race and class become surrogates. They see somebody with that description, they're like, no, I don't want to take, because that's going to mean more work. Furthermore, you'll have the hospital saying, get them out, get them out. So what happens?
Yes.
System puts that young person, that young doctor, nurse, clinician, in the uncomfortable position of saying, you got to get them out. Well, it's freezing outside. So you're actually asking them to make a decision that is against their own morals and ethics. So what do people do? They don't want to be in those situations. So they want to avoid taking care of that person. I mean, these, and you know, you can break it down psychologically about what that kind of distancing is. So because it's
basically cognitive dissonance, right?
Thank you.
We have some anxiety producing event, which is there's a person in need. I'm in a helping profession, so therefore I'm supposed to help that person. So that produces anxiety because you're not helping this person. So what you do is the way you assuage that anxiety is by making up things in your mind that makes it easier to not help that person. Like like when Miss Bass is going in, you say, oh, she's drug seeking. So now it's easier for that person to not help her because they were, oh, she's just drug seeking. She's not in a real emergency. So therefore, I'm still a good person and I'm still a good helper, but that person is not somebody that's worth helping, right? And so really it's that process that you go through, and you're right, you start assigning, we start simplifying mentally, oh, that person will tell you, oh, and then you start listening for cues that says, oh, this is not a person I need to waste my time with. I can move on to the next person.
Mm-hmm.
And that is problematic because, and in Ms. Bass's situation, she was saying those things that should say, oh, hey, this person has some knowledge, ability. Let me lean in and find out more versus, And so even in that case, and that's why when you were talking, and I know y'all noticed what I was putting on screen were those things that lend itself to disparities in healthcare, right? Race, ethnicity, socioeconomic status, age, geography, language, gender, disability status, citizenship status, sexual orientation, and identity. And when you start stacking some of those things, it becomes more problematic for people of color because if you're a Black female, now you've got two of those things. If you're a Black female of a certain age, now you've got three. Black female living in like rural Mississippi, it might even get worse, or coming from the 8th or 9th ward there in DC, it gets worse. So those categories start stacking in one person, and now they get pushed further and further out into the margins when it comes to engaging in healthcare. So that's that's how it can really happen.
Mm-hmm. So I want to tell you another story, and I'd like for you, Ms. Bass, to comment on this, especially given your experience with younger physicians and students in training. So, up until recently, I actually used to work in the hospital. Oh, thank you, Mr. Darren George. How are you doing? I love you too. So I would work taking care of patients in the hospital. So this is before COVID. I also took care of patients in the hospital during COVID. At any rate, so I picked up a service, and I'm learning the people that I have not met. So it's interesting how when students and people who are sort of, medicine is a very hierarchical system. Probably not quite like the military, but not far off. It depends on what area. Like orthopedics, neurosurgery is probably like the military, but there's a hierarchy. And what happens is that students and learners are really smart about knowing who is going to grade them. So they begin to adopt the lingo and the language and the culture. So earlier on, there's actually an interesting book called The House of God. And it basically talked about the culture of internship. They used to call patients coming from the emergency room hits, like you're up to bat, so it's a hit. They would call people, older people, gomers, get out of my emergency room. There were all these terms. And so when I was, starting off and educating people, I would forbid people to use those terms. And at the beginning, when they're still starting out, they understood. But then when they started to, hey, Mr. Maurice, it's one of our peeps there in New Orleans. So when they then began to realize who is going to grade them, they knew that they had to behave a certain way with me because they knew I didn't like that. But then they would join in the language. So I picked up a service in February. So the medical student was presenting. And, by that time, a little bit more confident. Yes, Black men do deal with doctors who dismiss their problems. It's everybody. So I asked her to tell me about the patient. Oh, and there was a lot of eye rolling. All right. So this patient is so-and-so, and he has arthritis. And she actually taught me something. It turns out that 50% of the cocaine that's sold in the United States is cut with a deworming agent. And to make it more and fluffier and so forth. And that deworming agent can actually cause your body to create antibodies that attack the blood vessels. Okay. So kind of like lupus. So this gentleman had come in with severe joint pain because of this vasculitis, inflammation of the blood vessels. So she taught me something. She goes, well, he was supposed to go today, but then he didn't want to go. He was homeless as well. I said, well, what's the temperature outside? What? I said, what's the temperature outside? She just looked at me like I had two heads. I said, I'll tell you what the temperature outside is. It's below freezing. And he's homeless. Of course he doesn't want to go. So I said, well, and he was somebody that was a substance abuser, and he was maybe in his early 50s. I said, well, when did he start? I don't know. What did he do? I don't know. She knew nothing about him as a human being. I said, okay, let's go in and see him. So the first question I always ask patients is, what do you know about your condition? He couldn't tell me anything. So I explained to him the whole drug thing and so forth. I said, how long you been using? He said, I started about 10 years ago. I said, 10 years ago? Well, that's kind of unusual. What happened? He said, well, I used to own a barber shop. I said, so in other words, you're a businessman. And then, there were problems with my, marriage. My wife left me and, so forth. I said, do you have any kids? And he said, yes, I do. And then he started to have tears running down his face. And he says, and I've got 4 grandkids. I said, so in other words, you've got to get clean for the people that love you. So as we were walking out the door, this very cocky young woman all of a sudden was red-faced with tears in her eyes. I said, well, what did you learn? She said, I learned that I'm a very judgmental person. Because that person that was back there, that went into medicine for all of the right reasons, was still there. She had been jaded by the system, right? And so, it was a teaching moment. I said, well, that's why I'm here to teach you. But when we have, yes, human connection, thank you, Ms. Conrad Williams, human connection is key. So it is sad when you're putting the burden on the person who is ill and feels like crap, excuse my language, in whatever situation. And, when we show up and we're not feeling well, it's not like how we look now. Okay. As somebody who was in the hospital in the ICU for 8 days, Miss Tracie can tell you what I looked like when I was in the ICU. It was not a pretty picture. Your words, I was on narcotics and so forth. You kind of lose your mind. So the language, even the way you express yourself, is changed. So Ms. Tracie, I want to come back to you, and I'd like to hear from you, because you've got a lot of experience, especially with these younger people. Because I want to talk about solutions and actions, because it's not, we know what the problems are. People have experienced them individually, but what would you say? What would you suggest for the people that were let's say in your situation, or, what would you say? Because like Mr. Ellis said at the top of the hour, we're always talking about advocate for yourself. And you couldn't.
I didn't have, as much as I tried to advocate for myself, nobody was listening. Nobody would allow me to finish a sentence. I was being cut off at the pass at every turn. And I think an important part of it is, as my grandfather used to say, you have 2 ears and 1 mouth. So that means you should do twice as much listening as you do talking. And I think that this is especially true in a medical setting. You have, as a physician, you have the degrees and you have everything else, but you have to listen to people, because sometimes what you need to know is in what they're trying to tell you, but they just don't say it in medical terms. So you have to allow them to vent and say how they feel and what they've been going through. And a lot of times the clues that you're looking for will be in those words.
So what do you say, though, to the person that's the patient? that's there. That, I mean, what are there ideas or solution? I mean, I have some ideas myself, but from your perspective, if you hadn't called me, who else would you have called? Who else could have?
Oh, I would have called the director of nursing. I would have called whoever was in charge in the hospital. I would have demanded to speak to, I want to speak to the house supervisor, the director of nursing. I want to speak to whoever is in charge here immediately. That's what I would have done. But a lot of people won't do that. A lot of people will not do that because in relationships between patients and doctors, patients often feel that whatever the doctor says is correct, and you don't go against that. You don't challenge them. And so many people, just whatever the doctor says, they go along with it. And another story is, and Dr. Gigi will tell you this. My sister was sick. She had been going to a dentist for 6 months. Every couple of days or weeks, her face would swell up. I went home to see her, and her face was swollen. Her eye was shut. She called me. She called me to her bedroom. She just started crying. She's 3 years older than me. I've never seen her cry up until that point. I looked at her husband. I said, we're leaving. I'm taking her back to DC with me because she's not getting what she needs here. Took her to DC. She saw ENT. He ordered a scan, or MRI, some CT something, and she saw infectious disease all in the same day. And I have to be honest and say that it won't happen like this for everybody, but because of I've worked with all of these people, I was able to get things going pretty quickly. Mm-hmm. Before we could get home, a 30-minute drive, they were calling me back saying, you have to bring her back to the hospital. She has to have surgery on her head or the infection is going to spread and it's going to kill her. Mm. And this is the dentist saying to her, oh, your case is so interesting. I'm not even going to charge you for the MRI that I did. I was like, yeah, I'm serious. This is what he was telling her, just dragging it on. Like, I've never seen anything like it before. It's very interesting. I'm like, she's not a science project, sir.
Yeah.
Mm-hmm. You know, and she just went along with it because that was her dentist. He was saying, oh, this should make it better. I'm going to give you antibiotics. I'm like, you have been on antibiotics for almost 3.5 months and then you're not better. I'm like, no, we're leaving. And that is exactly what happened. We left. We came to GW. She had surgery twice and was in the hospital for almost 10 days.
Mm-hmm. Mm-hmm. One of the listeners,
real quick, Dr. Gigi, ENT is ear, nose, and throat specialist, just in case.
Oh, I'm sorry.
I get it. You were telling the story. I didn't want to interrupt the story,
sure.
But just want to make sure our audience knows ENT is ear, nose, and throat specialist.
Right. And actually, I'm sorry, I missed the name. One of the people made a comment on the chat that, this deference, it's really about the power structure and the power dynamic, right? Thank you. As I don't know if it's a doctor or Ms. Francesca, and we are from a society culture that believes we do not question authority, our elders, professionals, etc. It makes it difficult for us to assert ourselves when need be. That is correct. And that's why it's important that in your case, your sister's case, that you are the one that advocated, because you just don't have the strength. Yeah. And sometimes when you're in it, and months go by and you're like, wow, I'm just going to give it one more thing. Oh, he's going to try, or she's going to try this. One more. So that's why community is so important. Back in the day where communities were intact, where the nurses and the doctors and the lawyers and the accountants and the teachers and everybody lived in the community, there were many, and the reverends and the preachers. That's way you could have people advocate, right? So there are a couple of other people that I would mention. You mentioned the house supervisor. So that's somebody that's in the hospital. You mentioned the director of nursing, but both in the hospital and the clinic, there is the patient advocate. And one of the things that any place does not like, clinics or hospitals, are bad ratings. So when you need to, you can call the patient advocate, you can call the page operator if it's the middle of the night. There are also ethics committees that are in the hospital. But you know what? When you have somebody that is calling or coming in and saying, I need to find out what's going on. She's not getting better, this and that, just like you did for your sister. And oh, by the way, do you mind if I record this or take notes? All of a sudden, you're going to see a shift. And God forbid if there's somebody that's coming that's a lawyer, that if you want to see doctors straighten up right away, just mention the word lawyer. I'm serious. Because, and then if you ask to record and, oh, what's your name? And write down the name of people, the physicians that are coming. It is very important for you to know who the physicians and who the clinicians that are taking care of you. What is their name, their rank, and their serial number? And when you're taking notes, people will start to pay attention. And if you can't do that, have a family member. I will tell you this, when there's lots of family in the hospital or in the clinic, people get more time with the doctor. The squeaky wheel gets the oil. It's true.
Absolutely.
You spend more time. I mean, that's human nature, right? Because people are talking. And if things are not making sense because you got a gazillion specialists say, I want to have a family conference where everybody comes together. And the social worker can be a great ally. Nurse, by the way, sometimes, not sometimes, a lot of times nurses are equally frustrated with the doctors, right? Because nurses are fielding all these complaints and they're being, ignored.
Who are some other people? I know you mentioned a few doctors, Gigi. If you could repeat that again for the
Sure. We said the patient advocates. There are patient advocates in any system, either as an outpatient or an inpatient. There's actually also clergy in most big institutions and hospitals, because you want somebody to advocate for you that can understand and speak in the language. Because as what Miss Tracie said, I thought was very important, is that it's like we're speaking different languages, right? People are not listening. People, they don't listen with this. They're listening, with I don't know what they're listening with, but at any rate. So patient advocate, house supervisor, director of nursing, there's ethics committees. You can call us the page operator. Yes, chief medical officer, patient experience. Thank you, Dr. or Ms. Coronita. The Office of Ombudsman. Okay. Well, here we've got some great suggestions here.
Yeah, the viewers are doing a great job. I'm like,
these are GME people. I can tell by what their answers are. Coronita, I know personally, but a lot of them are GME people.
Yes, thank you for that, because as Ms. Conrad Williams is pointing out, and her handsome husband, Mr. Adrian, basically there are these systems that are put in place. And I just want to talk about she and her husband, because Mr. Adrian, he's been very open about this, and I'm not saying anything that he has not said publicly before. He has sickle cell. Yep. And we know, because there are papers published about this, that 86% of people who have a sickle cell crisis do not come to the hospital emergency department because of how horribly we treat them. Mm-hmm. When somebody does come because of how horribly we treat them, their pain actually increases. Yep. So when you talk to Mr. Williams, he will tell you that he has to make sure that he gets dressed in a certain way because he's worried about being identified as a drug seeker, instead of like, I'm in severe pain and I need some medications. So what he has taught us is he tries to go to the same place and establish a relationship with the physician, so that when he goes to the emergency department, thankfully very few and far between, because he does a great job of taking care of himself, that the people know him, and his doctor can call down and say, okay, this is so and so, this is what he needs, this is what's important. So those relationships are important.
Yep.
um,
Could I add one thing? I think this is great. So you've got people within the system that you're going to add. So there's some great tips here, and I want to make sure that people really get this. There are avenues in the system itself that you can call to advocate for you or to file a complaint, right? Because you're right, doctors, they don't like, hospitals, they don't like getting bad complaints, and so there's avenues there. There are also things that you can do with recording is one thing, because they cannot say that they didn't say that, if they have to be called later on to say, no, I got you on recording, right? Can I write this down? Can I have my friend, family member sit in with me? Now you've got a witness. So that increases it. The other thing, and this is beyond the scope of what we're talking about a little bit tonight, but this is why it's very important to establish a relationship with a primary care physician. And I'm speaking to Black folks who sometimes we tend to only go to urgent care when we're not feeling well, or we'll present to the emergency room when something's wrong. We only go in when there's something is wrong. Go establish a relationship with a primary care physician that you see on a regular basis, because one, that's going to be the best way to prevent having to present to an emergency system, to emergency room, is by making sure you're up to date on your high blood pressure, your cholesterol, your man prostate, all of these different things, these screenings that you need to get done, and get those things done. Also, you've created an advocate, right? Because you've seen them on a regular basis. They know how adherent you are. They know they've got all of your records. And so therefore, if you're in a situation like Ms. Bass was, that person can go in and say, hey, no. Here's all her. I've been seeing her for the past 8, 9, 10 years. No, this is not, she's not playing around. She doesn't seek drugs. She's not like that. But if you don't have that relationship, it becomes harder and you're starting at square one. So not blaming you, I'm just saying that this is the time to establish that relationship, not only for your own health, but just in case you do run into a situation where you'll need an advocate that's going to be on your behalf.
I want to just talk about something which is all tied in, because we don't exist in isolation as people. And we know, and those of us that have been in the health system, and Ms. Tracie can speak about this, is that with the previous administration, the tone and tenor of how people of color, and we can also talk about other disenfranchised groups based on class, gender identity, etc., there has been a significant decrease in the quality of care, in my opinion, where all these kinds of anecdotes are coming up. There have been problems, despite the slogans of DEI and implicit bias and all that. I will tell you that there are some concerning trends. Yes. Thank you, Ms. Bird. If you're not being heard, switch is one of the things that we are always talking about.
I'm going to say, get you a good one, but you're right. Civility has been lost.
Exactly.
And it was lost.
Well, and worse. I mean, I think now with all the rollbacks of 50 years of legislation and progress, I think you're going to be seeing more overt racist behavior. And so it is important that if we care about these issues, about our communities, about Black bodies, Black minds, Black children, that this is actually beyond just the very narrowly defined physician-doctor relationship. Remember, social determinants of health have to do with education, with the economics of your where you live, where you work, the quality of air that you breathe, water, all of that kind of stuff. And that actually means that you have to be involved in your community and to vote, not just during the big elections. Actually, we were talking about this, and Mr. Ellis, can you talk about the school board? Because we were chatting about this beforehand.
Yeah, I was saying that there is an effort, right? And we see what's happening with this recent legislation, from the rolling back of Roe versus Wade to now saying that affirmative action is no longer applicable in college admissions. to everything we are seeing across to voter suppression laws being enacted all over the country. There is a real effort to roll back the progress that was made in the 60s from the Civil Rights Act and the Voting Rights Act. That there's too much evidence to show that. Um, and what we're seeing is voting is got to be local, start local, then work national. Because even let's say like if you had a fairly elected, if you walked in and you were voting for your mayor, your city council,
Mhm.
your state representative, then what's happening nationally doesn't have as much impact because they're not going to let it happen to you
Mhm.
and your state or your community. It's not going to. They're not going to allow it to happen. But if you don't do that, if you're just only voting in the national election, I don't care who's up there. It's if it's not going to get down, it's that state legislature, they're going to do what they can in
Mhm.
order. You see what's happening in Florida, and that's my home
Mhm.
state, so I'm going to talk about it.
Mhm.
You see what's happening in Florida. He doesn't care that Joe Biden's in office and he's trying to
Mhm.
build infrastructure and just, close the wage gap and the wealth gap in this country. He's down there literally
Mhm.
trying to do everything, the antithesis of that. And
Like
so,
who creates a law that says don't say gay? Who does that?
right. And so,
Him.
and then in Texas, they're talking about all these other things about anti-indoctrination while they're trying to indoctrinate kids into other ideologies, and that's really what they're trying to do by using that language. And so we have to be very, very careful. And I would say, Black people in general, so we're talking to Black folks tonight, supplement whatever your children, if you have children, supplement that education that they're getting in the classroom, because they're trying to separate us more and more and more from our history, and they're trying to whitewash it, pun intended, in a way that makes it not seem as bad. And so we have to, the only way that we can preserve our history is by telling the stories ourselves. Right. And there's a great oral tradition for people from African descent, and we have to continue that. And we've got devices that can help us continue that moving forward.
So what you're talking about is education, which, in DC, less than 50% of kids in this one particular ward, Ward 8, graduate from high school. If all we did was get them to graduate, we would add 10 years to their life expectancy. So it
Yes.
may seem like what's he talking about, school board, but education is actually one of the strongest social determinants of health. I want to come back to you just in the last few minutes, Ms. Bass. I mean, what would you say to well, let me ask it this way: are there particular groups that you feel are not heard more than others in your experience?
Um, I mean, of course, African American, women probably a lot more than men, and other brown people as well. But what I wanted to say was that with this recent legislation, I think that because there is going to be a decrease in the amount of diversity in people of color getting admitted into medical school, that it's going to increase the anxiety for both physicians and patients. And that really is scary to me
Mhm.
because less than 10% of physicians are African American.
Oh, a lot
Five
less.
percent. It's less than 5%.
And what, like 3% of that are less than three are males.
That's
Yes.
right. Like
Yes.
And
two to
so,
three.
I mean, so now what are we going to be looking at in the next 10 years? Those numbers will dwindle.
Yep.
Well, and then, I just want to also say, because I've collected a number of horrible stories over the last, just in a few weeks. And to be fair, for all the reasons that you mentioned, Ms. Bass, about how we can all be changed by the system itself. Sadly, there are some of us that perpetuate
Hmm.
those attitudes. I mean, there is an African American female physician who went to see one of my patients, and that patient had been in a bad car accident where there was a deployment of one of the what do you call it, the
Yeah,
airbags.
airbags, yep.
And that person had a pretty serious lung injury. So the physician, African American, was just not listening to her. That person ended up in the ICU.
Yeah.
So this dismissiveness, I mean, I think, we look at, how we identify individuals, which is important because studies show that when you are an African American seeing another African American clinician, overall, the outcomes are better.
Right.
But we can't discount, we can't, plus that's a lot of burden on those of us that, we're like the token. I mean, that's a lot. It's like we should share the wealth and everybody should be taken care of. But let's not discount the system, because actually the system does a lot to cause this jading process.
Mhm.
Absolutely.
Mhm,
I agree.
mhm.
I agree. I was reading an article today about a African American physician from Boston Medical Center named Vonzella Bryant, and she talks about working in the ER. And she says her logo at the start of her saying at the start of every shift is, "Today I'm going to provide exceptional care without exception."
Wow,
Mm.
nice,
I like that.
nice.
I like that.
It's
And
like,
everybody, I mean, and that everybody in healthcare should have their thought in their mind when their day starts. Or
well,
their
and the reality is we're human beings. My best is going to be different on different days. If I've had a fight in the family or if I'm not feeling well, I'm going to bring that, to work. But at least to remind ourselves, because, it is, first of all, it's a calling and we're dealing with people's lives. You make a mistake, that's somebody's life. That's somebody's child. That's somebody's parent, cousin, that's somebody loves that human being.
Right.
And I think the more that we can avoid that cognitive dissonance
Mhm.
and realize that these are people, that's why, when I'm teaching, I say, I don't want to hear the diabetic in room X. I want you to tell me Mrs. So and so, the grandmother, or Mr. So and so, the retired, whatever, fill in the blank. This is, and this is what those of us who are in these systems can do to push back.
Yep.
To correct people. I mean, that doesn't have to be, oh, you're doing this. No, tell me about so and so, to have that human connection. And the irony of all this is when we do that and we humanize others, we're going to be less likely to burn out ourselves. That's the
Mhm.
irony, is that human connection helps on both sides. So um
That's a great point there, Harry. I will just say as we're wrapping up here with Dr. Gigi, this was a fantastic show, and some of the comments are reflecting on that. Thank you, Ms. Bass. I will ask one thing for you all to please like and share this show. We want to get this out as many people as possible. So I see some people have already put their likes in there. Thank you so much. But please like and share this show. We want this information to be out there. Remember, when we say you're on your belt, you're your own best health advocate. Now we've given you some ways to really advocate for yourself, whether it's through the hospital system, whether it is through your own interaction with whomever, whether it's an emergency room physician or your own primary care physician. Have it, bring a buddy, record it, write things down. All of these things can help you advocate better for yourself. Of course, I'm going to be a little bit biased and say also by going to BDO.com, BDO.org, blackdoctor.org, and learning more about your condition and how it impacts Black people, so you're better informed about it before you even go to the office, and then become and then take care of yourself better, not just the mental, not just the physical, but the mental as well, because that impacts your whole physical well-being. Dr. Gigi, you take us home.
Well, thank you. And I want to just give a special thanks to my little sister, Miss Tracie Bass, who I'm so proud of, for really sharing her story, because these are not easy issues to talk about. So thank you for doing that. And I also want to ask if people have ideas for future shows topics that you want to hear about, please share them. And when am I coming back? We're coming back in 2 weeks. Two weeks. Wednesday is the 8th. So I want to hear from you about topics that are important to you. Because we're here to serve, and it's so good to be back in Mr. Ellis's company. And thank you.
Can I say one thing?
Please.
Please, 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 if you don't understand what a clinician is saying to you, don't say that you do. Because they have the ability to break it down for you to be able to understand it. So many older people, because it's just whatever the doctor says is okay. When you don't understand something, ask questions. It's okay. And it's their job to explain it to you.
Yep.
I think that's so important, because so many times we sit and just listen and say, agree, and not know exactly what we're agreeing to.
So, Francesca,
July
yes.
is Minority Mental Health Awareness Month. Can we focus on that? Yes, we will do that. That's going to be our next show, mental health.
Yes, we definitely will focus on mental health. And we're going to talk about how it ties to your physical health, right? We're going to talk about the importance of that. And then, and I'm going to advocate for Black men getting therapy, right? If you, and we're going to have to let go of the stigma. We're going to let go of our fears. We're going to have to find somebody that we trust that won't weaponize what's going on. We understand that as Black people. When I say that, we start sharing our personal stuff, it can become weaponized very, very quickly. So I do understand the fears, but there's so much of a connection between your mental health and your physical health that we've got to let go of some of that.
One of the most powerful sessions that we had at the blackdoctor.org summit was the Black Men Hurt Too.
Yep. Fantastic. So this is great. Thank you all for staying hanging with us for this hour plus. Thank you so much. We had a wonderful, wonderful program. Dr. Gigi, I can't say enough how I'm happy to have your show back here. Ms. Bass, you are the perfect guest to have on the kick.
Thank you for having me.
Call with the return of House Call with Dr. Gigi. Again, we'll be back in 2 weeks. We're going to be talking about mental health. So tell your friends, set a reminder. I will schedule it early. We will make sure we'll set a reminder. So we'll see you right here, 2 weeks, 8 p.m. on blackdoctor.org. Thank you all for joining us. We'll see y'all next time.
Take care.